So I've just started the webinar. Maybe we wait for a couple of seconds. So people are joining now. So I think it's 8 o'clock now, so we could start. So hello and good evening. I am Marlene Speth, and on behalf of the organizing committee and the ERS, I am very happy to welcome you to the ERS webinar series. We would first of all like to thank Olympus as a main sponsor. For those who are new to the webinar, please type your questions into the chat. So this evening we will be talking about obstructive sleep apnea. We have Dr. John Dabrowski from Boston. We got Jacopo Karagama from London and Professor Joachim Maurer from Mannheim, Germany with us tonight. And we also have my co-moderator, Wenche Mo Torstensen from Norway. We feel really, really honored to welcome our speakers from all over the world, from Boston, London, Germany, and Norway. And they're all very accomplished in the subject area, but most of all, they're also very nice people. And I would now like to pass over to Dr. John Dabrowski. He's board certified in both otolaryngology and sleep medicine and specializes in sleep medicine, sleep disorders, snoring, and sleep apnea. And he will be talking about the diagnostic workup of OSA tonight. So we'll start with his presentation.
Hello, hi, I'm John Dabrowski, and I am a physician and surgeon at Massachusetts Eye and Ear Mass General Hospital in Boston, Massachusetts. I'm an instructor at Harvard Medical School, and I am delighted and thank Marlene Speth for including me as one of the speakers in your obstructive sleep apnea webinar. I've been asked to discuss or review my diagnostic workup for patients with obstructive sleep apnea and sleep disorder breathing, and it's a pleasure to be participating with the other speakers to educate you a little bit more about this subject. I want to
sound.
You do realize there's no sound, don't you?
I don't hear sound either.
You're not. Marlene, I'm sorry, but there's no sound. Do you want me to go live and start over?
Can you hear it now?
Diagnostic workup for patients with obstructive
where
sleep
the sound
apnea and
was
sleep
there
disorder
as
breathing,
well.
and it's a pleasure to be participating with the other speakers to educate you a little bit more about this subject. I want to also thank the European Rhinologic Society for including me in the webinar. And this is the way that anybody can contact me, either through telephone or emails, and I'm more than happy to answer any questions if we can't get to all of them in the webinar. I'm pre-recording this so that they are able to monitor the amount of time that is required for the webinar. I'm very, very pleased to be part of Massachusetts INEER, which is recognized worldwide as one of the best hospitals in the United States, both in otolaryngology and in ophthalmology. The thing that I want to stress and emphasize is that when a patient arrives with a complaint of snoring or sleep disordered breathing, I have to explain to them that the snoring may just be simply a tip of the iceberg of a much greater problem, and that it's very important that we really dive into the entire picture and not just focus on one symptom, but that we can really review every aspect of their complaint, and so that we can give them the best opportunity for improvement. It's not only the patient that will sometimes come in complaining of the problem, but often bed partners. And they, when I see two people arrive for the same appointment, I usually deduce that there is some disturbances that are occurring in the bedroom. Sometimes the patient has no idea that they are even having difficulties or are annoying someone and disturbing their sleep quality. So it's very interesting and certainly want to keep this in mind, that you may be treating two people rather than just one. Of course, snoring is caused by the vibrations that occur as the air passes the soft palate, uvula, and soft and the base of the tongue, and this type of laminar flow can be affected by the airflow of the nasal passageway, but it's the vibrations of these tissues that cause snoring. This doesn't have medical consequences per se, and so consequently the management of this, at least in the United States, is not covered under insurance. However, other anatomical abnormalities that may contribute to medical conditions are covered. Obstructive sleep apnea or sleep disordered breathing, on the other hand, is a much more serious condition than simply snoring or nasal blockage, and has the medical conditions that are often associated, including cardiovascular, pulmonary, neurologic, and metabolic disruptions. So every patient's examination is an individual process, but we break it down into a number of categories. The first and most important is the overall appearance of the patient. And this will include a detailed head and neck examination, which will include looking at the patient's profile, their body habitus, their posture. All of these things play into their anatomy and the positioning that they find themselves most comfortable in breathing and exchanging air. Additionally, history about body position and sleep habits and positioning are equally as important as observed by the patient themselves or by other sleep members, or family members, I should say. Part of the examination includes the nasal, the oral pharyngeal, the tongue. However, a in-office procedure often will produce wonderful insight as to where the location of the majority of the obstruction is occurring. Occasionally, we will take patients to the operating room to do a more detailed exam under drug-induced sleep apnea. And this often will highlight additional collapse, particularly in the epiglottis. Now, we'll review any diagnostic studies that the patient brings in. Now, this may include previous home sleep testing, oxygenation or nocturnal oxygenation, even some of their own downloads and apps, because you have to understand these people are really getting connected and are concerned about their airways and what is exactly happening. So I'll spend time looking over their apps. Now, they're not as exacting as a home sleep test or better yet, an in-lab sleep test, but they do give you some insight as to some of the disruptions that they're having. And these include snoring apps, oxygenation or O-rings, and sleep apps in general. So I review all of those with the patient and try and explain some of the findings to the patients as a way of getting to know them, as well as having them understand my level of expertise. Additionally, I will usually require or request a CT of the neck that will include the sinuses. Now, the reason I do this, the oral maxillofacial surgeons really spend a lot of time detailing out cephalometrics and measuring different locations of landmarks. However, a lot of times I'm using this as a way of documenting the patient's airway, as well as providing a record prior to any intervention. Secondly, it gives me a chance to show the patient what their nasal airway may look like. Additionally, lateral views will show them positioning of the tongue, possibly some lingual tonsillar tissue that they are unaware of, as well as any nasal obstruction or sinusitis that would need to be addressed at the time of surgery, if surgery is going to be proposed. Then gathering up all of these different entities, I really often will explain to them the different modalities that we use in order to manage snoring or obstructive sleep apnea. So I do this all in the first examination. Now, and so I'm already tipping my hat towards CPAP therapy for obstructive sleep apnea, as it is, I still believe, is the most effective and least invasive of the management tools that we have. Besides, I get a sense from them also as to what if they're skittish about CPAP, or if they're willing and raring to jump into any modality that might improve their quality of sleep. Additionally, talking about different oral appliances and whether or not they are covered based on their findings of their sleep testing, it gives me a little bit more time to get an idea of what is the major problem in the complaint. Is it snoring, or is there actually a much deeper problem of obstructive sleep apnea and sleep disorder breathing? Now, I propose this as a way of reminding people to look at the global picture and look at it from all sides. Are you looking, first of all, a lot of times we're looking as surgeons at what are some of the things that I can do to help this patient? But I think you also have to look at the other aspect of it, to look at, let's look for the good of the patient overall. What is going to give them the greatest bang for their buck in terms of improving the quality of life? And that may include nasal surgery. Obviously we're addressing the European Rhinologic Society, and obviously nasal surgical intervention plays a key in management of both OSA with CPAP and with other just soft tissues. But it's important that we look and study the entire picture before we make any recommendations, particularly surgical intervention. So keep in mind, I know you've seen this picture many a time. Is it the eloquent young lady or is it the elderly woman? And it just depends on your point of view. So keep an open mind, particularly as you address a patient. Look for different avenues. In fact, every time a patient comes in, I kind of retest myself and rescore them, re-evaluate them and see, am I consistent in my examination and my assessment and what I am planning and recommending for the patient. Obviously, the examination begins with the nasal anatomy, and you all are completely aware and experts in the fields of evaluation of the deviated septum, the turbinates, allergic rhinitis, and non-allergic findings, as well as sinusitis and how this affects the nasal airflow. And it is particularly important for people that are trying to use CPAP or looking for improved airflow that may or may not help with snoring. There is quotes about 8% up to 10% of people can be improved by septoplasty and turbinate work alone in terms of improving their snoring and on some occasions even improving their sleep apnea. On the other hand, I've had some people whose airways improved so much that they now started to demonstrate central apnea. So it can be a double-edged sword. Again, the oral anatomy is very important in terms of occlusion. How do they have a narrow, high arch palate? Is the mandible narrow? Is the tongue being pushed posteriorly? The lateral walls and of the pharynx with the tonsils, how much they're contributing. And it's important that we grade these things so that we can score not only and communicate with our colleagues, but also we can evaluate when we initiate therapy, what things are we doing that, especially if we want to do some type of surgical intervention, are we making any improvement on? And this was the biggest problem that happened when UPPs initially were presented. After a couple of years, we started to look back at the UPP. We found that they were not all that effective, but that there are different characteristics and profiles that patients would have that had a better chance at improvement surgically, and others that would do better with CPAP or oral appliances. So grading of the Malampati, of the soft palate, tongue position, as well as the lateral wall collapse and narrowing is very, very important. In looking at the soft palate and how it hangs posteriorly, and how the tongue position also plays into this. And before surgical intervention of the soft palate is undertaken, I believe it's very important to have a full understanding of the anatomy of the soft palate and how the mucosal as well as the muscular characteristics of the palate contract, and how you can use some of these muscular bundles to sling or open up the nasal pharynx as opposed to just relying on reduction of tissue. Again, I cannot emphasize that the airway obstruction usually occurs in this retropalate, retroglossal region with contributions from the lateral walls. So it's very, very important that we detail out in each patient individually where the locations are. And you get an indication that if somebody comes in with a very high arch, narrow palate, that there's going to be crowding. There's, the mandible is narrow. That is contributing to upper airway obstruction. Again, I cannot emphasize how important performing a flexible laryngoscopy can be in terms of helping to establish where the obstruction is and whether you would be approaching this patient with CPAP or possibly surgery. I know that you often will be using rigid scopes, but on a patient that may present with this type of situation, you can use the flexible scope to perform the rigid endoscopy as well as the laryngeal endoscopy and grade patients based on a modified Mueller maneuver, basically performing inspiratory type of techniques, either drawing in through the nose or drawing in through the mouth with closed lips, creating negative pressure to look for instability of the airway. Now, we also discussed medical management in order to make sure that they have tried every avenue of improvement of the nasal and oral airway, and this will include nasal rinses, nasal steroids, anticholinergic sprays, and oral tablets, as well as decongestants. Again, therapy is graded and on the severity of the problem, the location of the obstruction. CPAP is the greatest management tool we have. It is the least invasive and most effective. The problem is compliance, and how in a lot of our patients, we spend a lot of time with them acclimating them to their masks, and we use AirFit P10 nasal pillows frequently because they're very forgiving and are not intrusive. We use heated tubing and heated humidification to make it more comfortable. And you know, I'd like to say we're probably 60%, 65% effective in selected patients. You know, I'd like to say it's more, but realistically, there's going to be failures, and those people you still want to have a relationship with because you may encourage them to move on to an oral appliance, or you may offer surgical intervention. However, curative surgical intervention is not always achievable, and that is the downside of this disease. Nasal surgical intervention can be tremendously helpful in improving patients' compliance for CPAP as well as effectiveness of their therapy. Lastly, you know, we consider where are the surgical interventions going to be most effective. How much can be done in the clinic? How much can be done in the OR? And some of these things are, you can go over this with the patient by demonstrating and reviewing CT imaging with them, and this helps you plan out your overall scheme for management. Turbinate reduction is tremendously helpful. We often use intramural coagulation to help cauterize the tissues, sometimes submucous resections. And lastly, you know, we reserve any of the soft tissue surgical procedures based on findings. So our initial evaluation is highlighting areas where we believe that we can make some improvement in our initial examination. Again, seeing things like elongated uvulas, can't wait to try and help out the patient, but overall, why are these so swollen? It's probably because there's a lot of snoring going on and collapse of the airway. If you don't address that, you may transect a uvula to reduce it, and you will have soft tissue swelling again. And using lasers are helpful in terms of stiffening of the soft palate and soft tissue reduction. Different techniques are employed for reduction of the tonsils, and even using palatal suspension sutures can be helpful. The most helpful or the best surgical intervention to improve sleep apnea has been modifications of this expansion sphincterplasty using the palatal fringes muscles to use as a suspension and rotation forward and laterally, opening up the nasopharynx. Again, reduction of the tongue through coblation in both the anterior and posterior portion of the tongue has been helpful, and occasionally using suspension sutures to the hyoid or the genioglossus advancement. Lastly, using a tongue suspension suture can be helpful, but I'm somewhat cautious with using this technique as it is a foreign body that may not last for a very long time. Again, we're trying to achieve improvement in quality of sleep for not only the patient, but often their bed partners. Again, we invite you to check into our snoring and sleep disorder breathing course that will be once again placed produced for November of 24 with one of my partners, Dr. Nicholas Busaba, and we invite you to participate in that. This is my contact, and please feel free to reach out to me. Again, I want to emphasize, look at all aspects of the patient's profile, their physical examination, their laboratory testing. Do not ignore retroglossal obstruction. It's the major cause of failure in surgical intervention. But as rhinologists and nasal surgeons, you offer a tremendous advantage to improvement of compliance and effective management, and you can assist your colleagues in the management of obstructive sleep apnea. So thank you very much for your attention. And if you have any further problem or questions, please reach out to me. It's been a pleasure to participate in this webinar.
So thank you very much for your talk. We would like to remind you, if you have questions, to put it into the chat or into the Q&A, and we will take them at the end. Now for the next speaker, the next panelist is Yakubu Karagama. He's a qualified ENT consultant and leads the multidisciplinary specialist voice clinic at Guy's and Thomas Hospital in London. He will now talk about electrical stimulation of upper airway muscles in OSA.
Hello, my name is Yakubu Karagama, consultant laryngologist based at Guy's and St. Thomas's Hospital. As you can see indicated by the arrow there, that's where we are based. This is in central London, more or less between the Tower Bridge and the London Bridge. And besides the shared building, that whole building, you can see it on the left side there. So you're welcome to visit us whenever you're in London. So I'm glad to be talking to you about the issue of obstructive sleep apnea. As we know, this can cause significant comorbidities, and this ranges from high blood pressure, stroke, heart attack, AF, diabetes, liver problems, memory problems, skin aging, depression, and even nocturnal polyuria. So there are certain risk factors that are associated with OSA, notably obesity, but there are patients that their BMI is less than 30 and they can still experience OSA. Also large neck circumference, family history, alcohol or sedative use, smoking and nasal congestion can all predispose to OSA. There are also clinical risks that you need to be aware of that may be associated with sleep disorders breathing. This ranges from certain cranial abnormalities, nasal obstructions, mandibular problems, narrow, short, and tapering axillary arch, maxillary arch, etc. So the initial investigations for The management of OSA and the diagnosis will include a full history and lifestyle. We are all accustomed to the Epworth Sleepiness Scale, which measures the severity of daytime somnolence. And then you carry out your full ENT examination from nasal endoscopy of the nasal passages, nasopharynx, oropharynx, and laryngopharynx. Also, sleep study will give you the diagnosis for the OSA, and this can be done in the laboratory using the full-scale polysomnography, or this can be done at the patient's home. Once you establish the diagnosis, and these patients are normally offered CPAP, that's continuous positive airway pressure, as a standard treatment. In certain cases, surgical treatment may be required, and again, drug-induced sleep endoscopy may help you to identify the level of obstruction. Imaging can play a role as well, especially in patients with craniofacial abnormalities. The standard management of OSA begins with lifestyle changes to review the patient's medication and even dietary requirement, i.e. to help patients lose their weight. You may even need to refer the patients to a dietitian. Also, other surgical treatment ranges from CPAP, which is a standard treatment for it that has been usually issued by the sleep physicians. However, and sadly, even though the treatment effect is very, very good with CPAP, but the failure rate is very high. In some studies, over 90% fail to comply at 3 years. The failure rate is similar with mandibular advancement device as well. And often patients with severe OSA, you may find that a mandibular advancement device will not correct it satisfactorily. There is also, there was a study that showed there is no significant changes at 3rd and 12-month compliance between CPAP and MAD. Now, there are different devices that have been used for OSA. One of them is the Excite OSA. Again, the benefit is variable, and that may depend on the severity of the OSA, as this device may not be very effective in patients that suffer from moderate to severe OSA, but may be helpful in patients with mild OSA and snoring only. So the management of OSA should begin by examination of the nasal cavities. If there are obstructive structures, i.e. like deviated nasal septum, hypertrophy of the turbinates or nasal polyps, or any swellings that may impede on the airflow in the nose, may need addressing. Other treatments may involve the soft palate and pharynx, tongue-based epiglottis, mandible, even bariatric or tracheostomy has been used for the treatment of OSA. So now, if the CPAP failed, if the patient returns the CPAP to you, what are your thoughts? I think in most cases where there are no other treatment alternatives, in the past, most patients are left with no other treatment modalities, hence they are more likely to go on to develop the complications associated with OSA. Inspire hypoglossal nerve stimulation therapy has now become more or less not an uncommon treatment for obstructive sleep apnea. This device consists of 3 parts. So there is an electrode that is attached to the nerve branches to the tongue. There's the hypoglossal nerve branch that protrudes the tongue. There's also a pulse generator that is inserted deep to the skin on the chest wall on the right side. And there's a sensor in the intercostal space that measures the intrathoracic pressure. I'm going to go through some of the surgical techniques for that now. But what are the indications for hypoglossal nerve stimulation implant? The main indications are moderate to severe OSA, that is between 15 to 65 events of obstruction of more than 10 seconds per hour. Also failed CPAP. The failed CPAP definition can be variable. A lot of patients may not be able to use it due to claustrophobia. Other patients, it may be just mere discomfort. And then sometimes noise from the machine may wake the patients up, or the sleeping partner. And there's also there are patients that complain about the dryness from using the CPAP. The BMI requirement should be less than 35, although less than 32 is better. Then once the patients have fulfilled the above 3 criteria, then you can book the patient for drug-induced sleep endoscopy. And this is mainly to filter out patients that will not benefit from Inspire. Patients that have tongue-based collapse or anterior posterior collapse of the soft palate are usually it will be selected for the hypoglossal nerve implant. I'm just going to play this animation for you now.
This monitors your breathing patterns during sleep. Based on your unique breathing patterns, the system delivers mild stimulation to key airway muscles, which keeps the airway open at both the soft palate and tongue base. With an open airway, fresh air can flow more freely to the lungs, and a normal sleep pattern can resume.
So basically, this is how it works. NICE have already provided an advice and guidelines regarding this in 2017. And I think now that we've started offering this procedure, it will again be reviewed. But the NICE guideline is that in the United Kingdom, this procedure should be done under audit format. That is, you'll need to monitor your outcome as you do the operation. And I think we're used to monitoring the outcome of surgery. And there is a very good clinical audit tool that is provided by NICE, which is very useful. As you can see on the top table there, and some of the complications that should be looked out for, and also some of the outcome measures that needs to be considered when doing this procedure. So the literature actually is very good with this. This is published literature in the England Journal of Medicine following the initial randomized trial that was performed in the United States. And it shows that the average sleep apnea events there's about 78% reduction in sleep apnea events per hour after using the Inspire, as you can see on the graph there. Before Inspire, it was 29.3 hypopnea index. And after using Inspire, it's about 6.2. There's been a recent study that showed that this continued up to 5 years. And that's the maximum follow-up that has been published has been 5 years. The implant itself, the battery life is about 10 to 12 years before it will require changing, and this can be changed under local anesthetic. Also, although this operation is not indicated per se for sole treatment for snoring, but as a sideline, this procedure has shown to improve snoring as well. And the sleeping partners, reduction in bed partners, report snoring showed about 82% reduction in bed partners reported snoring. Also, there is 97% reduction in bed partners leaving the room due to snoring. So you can see that it's not just the patient that benefits from that, but the patient's bed partner as well. So this procedure has been approved at Guy's and St. Thomas's Hospital. I first presented this to our Trust Risk Assessment Committee in 2019, and we had a slight delay to start this procedure due to COVID lockdown. However, I was able to install the first 2 cases of hypoglossal nerve implant in the UK on the 2nd of February 2022, and I've done 4 cases since then. So the first 2 cases have more or less similar demography, and they both have severe AHI. You can see there, it ranges from 37 to 63. And the BMI, again, is under 30 in both cases. And this was the drug-induced sleep endoscopy outcome from the first patient that I did You can see there's palatal level collapse and it's an anterior posterior collapse there. There's also tongue-based collapse, as you can see there. The epiglottis is completely clustered to the posterior pharyngeal wall. When I do jaw thrust, you can see it opens up the hypopharynx and then the oropharynx. So the implant technique involves certain stages that are very crucial, and you will need to identify certain nerves, and you need to use nerve monitors as well once you identify those nerves, because if you put the electrode cuff on the tongue retractors, this is going to result into failure of your operation. So the key nerve branches that you want are the cervical, geniohyoid, and genioglossus, because these are the muscles that protrude the tongue. Transverse and vertical muscles are included as well because it stiffens the tongue. And the one nerve that you want to avoid is the nerve supply to the hyoglossus, because this is a tongue retractor. And if you by mistake put the electrode cuff on that nerve, the operation will not work. The next step of the operation is by inserting the electrode sensor in the intercostal space. As normally you insert that between the internal and external intercostal muscles at the second intercostal space. So again, these are really just some steps on the dissection for the implantation of the pulse generator. So this is the external intercostal and intercostal muscles where you insert the electrode, and this is what it looks like. Again, this was my first patient. The first picture they showed how I insert the nerve stimulator, and then the middle picture at the incision in the neck and chest. The neck incision is about 5 centimeter incision on the right side, just 1 centimeter below the angle of the mandible, and about 5 millimeter from the midline. The chest incision, again, is about 5 centimeter down from the clavicle and 3 centimeters lateral to the sternum, and the length of the incision will be about 5 centimeters. So you're going to need microscope when you identify the nerve structures that protrude the tongue, as you can see over there on the left picture. And then the picture on the right indicates the insertion of the electrode for the chest sensor. And then once you identify the nerve and inserted the cuff, you will need to connect the electrode on the hypoglossal nerve to the pulse generator on the chest wall. And the pulse generator electrode is connected to the chest leads that measure intrathoracic pressure. This is just tunneling for delivery of the cable from the incision in the neck to the incision in the right chest wall. And then once you do that, then you will need to connect the electrode cable to the pulse generator, and you create a pocket on the right chest wall there for inserting the pulse generator. After the operation, you do an X-ray of the neck. Usually we do that in the recovery room, a chest X-ray as well, just to confirm the position of the electrode and then the pulse generator. If you're not able to do this on the same day, you can do that the next day. Again, this is testing the tongue movement. So this, at the end of the operation, we turn the device on, and we stimulate the tongue to check that it is protruding when the device is on. So you can see the tongue movement there.
Yep. You can. That's the tongue. That's great. It's excellent. Coming out.
So again, this is just some videos on how to identify the hypoglossal nerve. So in this case, I made a right neck incision just below the mandible, and you can see the hypoglossal nerve, and this is one of the, this is the C1 branch And this is the protruders, the genioglossus branch. You can see stimulating it. And you create a tunnel underneath the nerve. And you put like a vascular loop just to keep the nerve in view. And after that, you check again to be sure that you get the right nerves. You can see these are the tongue protruders. And when you check the retractors, you can see the retractors posteriorly. Once this is confirmed, you can now put the curve and then put some saline to remove any air in the curve. And then you secure it with a silk 3O. And the next is the placement of the sensors through a right chest wall incision. So you create a pocket there for inserting the pulse generator. And this is the pectoralis major muscles. You separate them, and you can see the fat part there, and beneath that will be the external and internal intercostal muscles, where you create a small pocket to insert the pulse, the sensor. Once you do that, you secure it with silk 2O or 3O. And then you check for pneumothorax by putting some water in the wound and have like a Valsalva maneuver. And once this is done, you do your tunneling. This is the tunneling from the chest, from the neck wound incision to the chest wall. You have to be careful not to get some blood vessels there. And the tunneling will be above the clavicle, because if you go below the clavicle, you're gonna end up puncturing the lung. It will not be a very good thing. Again, this is the electrode being inserted to the pulse generator. So both the electrode from the neck and from the sensor on the chest wall are connected to the pulse generator. And this is then inserted back into the chest wall pocket and close. And at the end of the procedure, you need to, again, as I've shown earlier, to check for nerve movement. This is just the sensor being secured. And there's a pulse generator being inserted. Once you do that, you close your incision, and that's it. And this is the pulse generator is actually small. It's not much bigger than the pacemaker. So you can see here, we're just testing the tongue movement. So there could be complications from this procedure. This may range from mild weakness of the lips and tongue, which I experienced in one of my patients. One of the patients also could see the contour of the wire on his neck. And this was because he wasn't exercising his neck adequately, but all complications resolved within 3 months. The third patient had no complications, and I did the fourth patient just last month, and he's due to have his pulse generator activated next Thursday. Again, this is just a patient that had mild weakness on his lips, and it's not paralysis. I think the weakness will be from platysma, because that resolves very quickly. You can see again, he can move his tongue. The right. The left again. The right. There it is. Again, another patient said when he extended his neck, he could see the wire, but these effects become less so after 12 months. So this was one of the patients during activation. You will see that during activation, the tongue moves forward and it opens up the airway. So close your mouth, just like you're going to be asleep. So this is what happens when the patient is asleep and when the machine is turned on. Again, this is one of my patients that I review. This is 12 months post-op. And just to show you how the patient turns the machine on. So
And the sound is not great. So what I'm trying to say here is that the outcome, the AHI, you can see it's dropped to 2.8. So you can see there's a significant improvement. And this is the outcome from our patients. You can see it is comparable to the published literature. So if you can mute it, I can talk over this.
Fantastic team at Hospital has participated and helped me develop this. And also, I will be very grateful to Professor Marcel Cooper, the sleep surgeon in Netherlands, who without him, I would have struggled to start this. And he came to me for my first case in February 2022. And this was after I visited him in his center in Netherlands to learn this procedure. And I also like to thank our ENT managers, the theater teams, and the company reps who are very supportive and are still supportive. Thank you very much.
We would also like to say thank you. And we would like to take questions at the end. So if you have questions, just put it into the chat. So now we would like to go over to our last panelist, who is Professor Joachim Maurer. He works at the University Hospital of Mannheim and is the head of the sleep section. His research is mostly concentrates on sleep studies, and he's also won many prizes and is quite well known in the area. And he will now talk about surgery, nasal surgery in OSA. Thank you very much.
Thank you very much for inviting me for this webinar of the ERS, and thank you very much for that kind introduction. Well, after this talk about the diagnostic workup and the overall possibilities we have when treating patients with obstructive sleep apnea and snoring, and after this this bright look into the future with hypoglossal nerve stimulation, which we've just heard about, I would like to go a little bit back and talk about the nasal surgery. When we talk about that, then we know that during the 80s and during the 70s and during the 90s, so many years ago, nasal surgery was, let's say, the stronghold of the first treatments of obstructive sleep apnea by us ENT surgeons, because it was found that nasal breathing and obstructive sleep apnea and snoring were kind of somehow linked. And after my conflicts of interest, I would just remind you that the nasal breathing is the physiological way. So while awake and asleep, we normally should breathe through the nose. And only a small percentage of our population is mouth breathers. When we talk about the airway resistance, and obstructive sleep apnea is talking about an obstructed, so highly resistant upper airway, the nose is the major resistance area while we are awake. More than half of it is due to the nose. When we now lie down and sleeping on the back is typical for us, not sleeping while sitting. So lying down is already increasing nasal resistance tremendously. And nasal resistance does not increase further when we fall asleep. So lying down is already one major factor for increased nasal resistance. When other measurements are taken into account, then during sleep, it has to be recognized that nasal resistance is much lower than oropharyngeal resistance, and that's just the opposite of what we have during wakefulness. So the nose, as we know it for now and for today, is a contributing factor for upper airway obstruction, so obstruction of the throat, and it is found often. So there are several studies over the decades, and just let me summarize one of the very recent ones that here in this upper study by Italian colleagues, half of the patients, they had clinically relevant nasal obstruction. That was objectively confirmed by, as we know, a weak tool, but still confirmed. On the other hand, there was no correlation between nasal resistance nor chronic rhinitis and AHI. So the number of obstructive events and apneas and hypopneas was not related to the nasal resistance. And patients with OSA have increased nasal resistance. They exhibit a significantly lower apnea index and higher hypopnea index, higher hypopnea to apnea ratio compared to OSA patients with low nasal resistance. That sounds a bit strange, but that just shows that those who are still breathing through the mouth and have increased nasal resistance, that is more typical. Whereas those who have completely obstructed airways in the throat, they probably don't need an additional increased nasal resistance to have these apneas. Now the question is whether nasal obstruction really promotes OSA, and all the data we have are quite conflicting. A very recent publication of, let's say, an international consensus paper, where I had the pleasure to be part of, was maybe it's already printed, but it is online available for half a year now, where all the data was put together, published until 2021, and the data are conflicting regarding patients with the risk of sleep disordered breathing and nasal obstructing. And just to mention that snorers who underwent posterior rhinomanometry, that for those who are just snoring, nasal obstruction was an independent risk factor for OSA. So the milder the obstruction is, the more important nasal breathing becomes. And in the large Wisconsin sleep study, those with self-reported nocturnal congestion, and they had a threefold increased incidence of snoring. Again, snoring, not obstructive apnea. And in an older study of Itzhak, there was no difference in apnea or snoring severity between nasal resistance severity groups. So this is a bit conflicting, but it all points to nasal breathing being somehow a risk factor for milder obstruction, such as snoring and hypopneas, but not a really important factor for apneas. But nasal breathing is a relevant factor for CPAP failure. So all those who do not tolerate nasal CPAP or also a full face mask, they have very often nasal problems. And if you look at those marked with a red arrow, claustrophobia very often is linked also to nasal obstruction and congestion. The mask discomfort can be due to nasal obstruction. Sleep difficulties are improving when nasal breathing is better. The inability to keep your nasal mask on is also something which is more difficult or is more likely when you have nasal obstruction. Suffocating sensation, congestion feeling, and an air leak, all those are typically found more often in patients who have an obstructed nose. So the another study showed that there was a correlation, and that there is a correlation between nasal obstruction, sleep quality, quality of life, and daytime sleepiness. So you have here the Epworth sleepiness scale, you have the quality of life and the functional outcomes of sleep questionnaire, the insomnia severity index, and the nose score for nasal impairment. And it is important to know that nasal obstruction is causing sleep problems and affecting quality of life. And so my question now is, what is the role of nasal surgery? Is it to improve the AHI, so the sleep disordered breathing? Is it to improve sleep quality? The data point to that. Is it to improve daytime symptoms, to improve CPAP adherence, and maybe to reduce CPAP pressure? And the last question is, does it enable other therapies if we breathe better through our nose? in principle, there was a major study, an old study already, which had a randomized trial. So they did sham surgery, sham septoplasty. Behind a curtain, not the nurse nor the patient knew whether the instruments were put into the nose without doing anything, just making noise, putting a packing, and leaving the patient after the time was over, or whether this surgery was really performed. And they found in this really outstanding study, and I just know that my ethical board would never accept such a study, that there was really no difference of the AHI before and after nasal surgery in this case series, but a randomized study as well. So also case series didn't show a difference. If you now look at a recently published meta-analysis of nasal surgery, and you can find that it is a little bit pointing towards a favor that nasal breathing improvement by nasal surgery is reducing the apnea-hypopnea index. So in more than 500 patients, the reduction was 4.15 after nasal surgery. But we have to ask ourselves, is that relevant? Just a mild improvement of the apnea-hypopnea index of 4.15 is clinically not relevant in most cases. There are a few patients who will improve, but the majority will not. Let me take the sleep quality and the daytime symptoms together. In the same meta-analysis, there were more than 300 patients within 11 studies where a far stronger effect was found regarding daytime sleepiness by improving nasal breathing. So increasing the daytime sleepiness on the Epworth Sleepiness Scale by 4 points is really clinically relevant. So even though the AHI didn't improve relevantly in most patients, the daytime sleepiness improved strongly. And if you compare that with CPAP, I think this is really an interesting finding that in this case control study, the nasal surgery did not improve the apnea-hypopnea index, but it improved oxygenation and sleep quality, whereas CPAP improved all three. And the improvement of the daytime sleepiness was even a little bit stronger and even significantly more in the surgery group compared to CPAP. So we should probably detach the nasal improvement and the AHI from other parameters regarding sleep and daytime sleepiness and even oxygenation. Let me come to CPAP adherence. I already showed you that many problems with CPAP masks and CPAP adherence, they are linked to nasal obstruction. And in this study, an older study, just to show you as an example, the acceptance and the non-acceptance group differed significantly in the AHI, but also in the nasal resistance. So the acceptance group had a much lower nasal resistance compared to the non-acceptance group. That is easily understandable for us, that improving nasal breathing should improve adherence. And it has been shown in another study that Mario Camacho is doing a lot of these meta-analysis and where regular use, adherence or tolerance of the CPAP device, they increased from about 40% to 90% after nasal surgery. And in the majority, again, about 90% of those patients who could not use CPAP, that they could do so after having surgery for nasal obstruction. So it's really worth looking at the nose, and this is always our, let's say, strong recommendation to all those who are not ENT surgeons, that they just don't just change the pressure or do whatever, a new mask, but they really have cared for the nose, have cared for the nose, and that they send the patient to an ENT. The adherence is also increasing by hours per night from 3 to 5.5 hours in this study of Camacho I already mentioned. And the patients use CPAP more per night compared to placebo controls. And intolerant patients used it even, well, if they were intolerant before, they used it more than 4 hours per night on more than 70% of nights. So again, this is all in a big favor for improving the nasal airway, nasal breathing, if you have CPAP problems. And the last 3 patients of this group, they didn't need CPAP anymore. They were lucky guys. Maybe they have to use it a year later, but at that time they were lucky people. Reducing CPAP pressure is always being said, and it seems that if you do septoplasty and turbinate surgery, the improvement in terms of pressure reduction is higher and superior to turbinate surgery alone compared to septoplasty alone. Patient number, as you can see, is low, only 82 patients. And average pressure reduction is at 2.6 centimeters of water. This is only made by case series. We are just doing a randomized controlled trial with nasal surgery, looking at CPAP, automatic CPAP devices, pressure areas, pressure ranges, percentiles, controlled setting. And it's hard to get patients, honestly, but we are struggling. So we hope that we will have our study ready in about 1 year's time. And then we know it by a randomized trial whether this is really true, that you can reduce pressure, or whether the improvement of adherence is mainly due to the comfort and not to the pressure reduction. Of course, we also know that if you have a nasal mask, then the impact of nasal surgery must be higher compared to using a full face mask. And that's shown here, that the pressure reduction seems to be more 2.8 compared to 2.6 when you take all patients in one pot. So at the end, enabling other therapies, of course, doing nasal surgery, then this is a major part in a multidisciplinary algorithm in CPAP failure, where you can see all different interventions, UPPP, tracheostomy, even MMA, genioglottal advancement and higher suspension, tongue-based surgery, hypoglossal nerve stimulation, and so on. So nasal surgery plays a major role in a multidisciplinary approach. So I would like to conclude that OSA and nasal congestion, they both affect sleep quality, daytime sleepiness, and quality of life. Nasal obstruction is a common reason for CPAP failure, and it correlates with poor sleep. Please do not tell patients that nasal surgery improves their AHI relevantly. You may have some few lucky people, but in average, it doesn't change it relevantly. But on the other hand, it improves sleep and daytime sleepiness relevantly. And it reduces CPAP pressure in these case series. And even if it doesn't, maybe, then it will for sure improve CPAP adherence and tolerance. And that means that nasal surgery plays a major role in sleep apnea patients. And I think that we, as ENT surgeons and rhinologists, we should really tell our colleagues from other disciplines that they should never forget the nose. Thank you.
Thank you so much for the wonderful talk. Thank you very much to all panelists. Now, regarding questions, we have already some questions going on in between our panelists. I would just like to repeat it for everyone. So the question was regarding MRI restrictions for patients post-implantation of a stimulator. Could you maybe just...
Maybe, John, you can talk about the US because it's different from Europe. Please switch on your mic.
Thank you. Yes, so it's been approved for all 1.5 Tesla MRI units. And so The problem that we find is that a lot of the detailed MRIs are using 3 Tesla units now or even higher. And so once again, that's something that needs to be discussed with the patients. However, 1.5s have been pretty standard in use for quite a few years. I do explain to the patients that this may be a limitation for whenever they're referred for hypoglossal nerve stimulation, and that they have to take that into consideration if there is going to be any detailed musculoskeletal or possibly even anything, with males for prostate MRIs and things like this.
May I add a comment regarding Europe?
Please.
In Europe, we are still at the old version. That means only the limbs and the head are allowed. So that was before. And the MDR, the medical device regulation in Europe, is a little bit having a bunch of applications for medical devices to be approved. And also this is still waiting for approval. So we have to still officially stick to the old version without the thorax and the abdomen and the hip. But if we give the American recommendation to our radiologists, then, well, some dare to do it, others do not. Depends on their, let's say, their
Comfort.
courage and
Mhm.
comfort.
Yes.
And then we have another device, that is the Genio device. This is a non-battery worn, so partially implantable device that's approved in Europe, CE marked, and we are doing this since 2014, and it's CE marked 2019, and this is MRI compatible up to 3 Tesla. So this is sometimes a reason why patients go for the bilateral Genio implant and others and do reject the Inspire device. Even though the experience is much less, we are using Inspire since 2010 and Nyxoah Genio since the new one since 2019. So this is really a big difference in experience. But this is then sometimes a decision-making fact.
Yeah, that is my understanding as well, that similar to you, Joachim. But the head, the neck, the head, and then the extremities, but the thorax and the abdomen, you will need to consider alternatives like high definition CT scan with contrast if needed. And quite often CT scan of the chest is sufficient because MRI of the chest is usually, because of the movement artifacts, it's not usually the first treatment modality, but the abdomen may be different. And I think in the worst case scenario, whereby the MRIs can have to be done, then in which case, I think it could lead to the device being removed, which is not a big problem because it's just an incision on a local anesthetic, and then you can reinsert it perhaps. I'm not aware of a case that requires that to be done. I don't know if any of you have had a case whereby the device had to be removed or MRI scan. Have you come across anything like that, anybody?
Not me, because we then just switch to other modalities.
You mentioned about Nexio. What's your experience?
Oh, sorry, we had one patient, sorry. One patient who also had problems a little bit when using it, who did not respond extremely well. So then at the end, the decision was made that he wanted to be removed, and he was going for an oral device after that with some acceptable outcome.
All right, so it was removed because of an MRI scan, but
that was the final step. Yeah, the final reason, after having problems, a little bit insomnia, and not being able to use it that well, and the outcome was so mediocre and not perfect. And then at the end, the MRI was needed, and that made him say, okay, now let's take it out.
Okay, just out of interest, you've mentioned you've started using the Nexio. I know you've been using the Inspire for a long time. What's your feel? What's your thought when you compare the two? I know you probably
the thought is that with the Inspire device at the moment, we have a much more well-established surgical approach in terms of where to place it, how to place it, and we have just much more experience. And with an IXOA device, the idea of having a bilateral stimulation is smart. The idea of having one incision only is also smart. The stability of the device now is no issue, but some patients would not like having the disposable patch taped to the submental area every evening. If you have a beard and you do not want to shave, then it doesn't work. The second thing is that placing the pedal electrodes is a little bit tricky. It's not that easy. You have a flat rectangular electrode where you have then an electrical field which is flat on the nerve. So if your nerve is like this and you have this rectangular part, rectangular part on your nerve, if that slides off of the nerve, it's not as easy to fix it properly compared to a cuff electrode which is wrapped around a nerve. So this is a really big difference in how to place it. You can do it, but it's a little bit less. I don't know whether I take 20 minutes per side to place it correctly or 1 hour and 30 minutes per side. So this is in time. The time of surgery is unpredictable for me still.
Right. So maybe still early days, but we don't know. We may find out. Is it CE mark officially now in Europe?
Yes, since 2019.
Okay, so
yeah, but it's a good additional possibility, and in some patients, it's really because it's small. You have no battery implanted, and you have the 3 MRI Tesla possibility. So,
what about? May I ask a question?
Sure.
Right. Patients with Down syndrome. What have you experienced with using patients with Down syndrome? Okay,
yes,
so
they do well. I don't know about you, John.
Yes, at Mass Eye near Chris Hartnick has done about 30, I believe, Down children, adolescents. He's gotten approved FDA approval for Down syndrome, and it's been remarkable. The first
it's been approved.
I'm sorry.
Is it been approved now?
I believe so. Yes. Yeah. He is.
He published it. I mean.
Yes, he's published it. I cannot be certain that it's been approved yet.
I don't think so, but for single indication, probably you get.
Yeah, he has a study group, I should say, that and there has been about close to 40 patients that have been studied, and without any serious complications. And I was involved with some of the original procedures, and it was the one that was most remarkable was a young man that was trach dependent, was able to become decannulated, and has done remarkably well. Some of the issues we've had have been some wound irritations from picking at it, but otherwise patient selection is always the most important thing.
I have only a few patients, like 5, and they are also young adults. I didn't dare to do it in adolescents so far, so I was always waiting until they are 18 years old.
Yeah.
But they really do tremendously well because they have the muscle problem, and that works well with the stimulation.
How do you deal with the consenting issues with the patient with the Down syndrome? Who signed the consent for this patient?
Depends on the Down, on the mental capabilities. Some of them they can do themselves.
Yeah, but if they can't do, then you have to do like I've got a patient that has been referred to me, which is why I'm asking this question. It's to be my first patient, and so we had a best interest meeting with his respiratory physician. So I'm going to see the patient. I presume if the patient cannot tolerate nasal endoscopy, a lot of them will do, but if they do, you just follow the same way as you do for any other normal patient, diets and everything. But if they don't, then you have to do all that under sedation, I presume.
No,
So-
I'm good experience.
Go ahead, Marlene.
So I was just trying to close. Do you have any remaining questions, or maybe also within the group, maybe to John Dabrowski in the stage, or anything else you would like to ask?
John wants to go to the OR. He's waiting to do the next surgery.
Yes, that's it. There we are.
I'm waiting to go
I
to
wanted
bed.
to do a nasal
I'm
surgery
ready
to
to go
improve.
I'm ready to go to bed now, John.
Yeah. That's it. That's nice to be on the other end of it. But I
I would-
cannot emphasize the importance of the nasal surgery, not only for CPAP compliance, just improvement of patient quality, and having that also as part of the overall soft tissue surgery that you may end up doing for the airway.
Just one last question from me for people that are doing a hypoglossal nerve stimulation. If you have other anatomical obstructions, say blocked nose, would you sort that out before you offer them Inspire?
If it's clinically relevant, yes, because it might be a reason for PAP failure. So I would always do that.
Yeah.
And if they have a blocked nose and they have a stimulator working, it may also be problematic for them.
Yeah, that's what I thought. Because I had a patient that also came to me. This patient has grade 3 tonsils, and an AP collapse would have been suitable for Inspire, and there's tongue-based collapse as well. The patient has massive tonsils, almost grade 4 tonsils. So I took the tonsils out and I did a barbed wire pharyngoplasty, which unfortunately didn't help with the OSA. But I've implanted the patient a month ago. I'll be still activating it next month. But I feel that the fact that we've taken the
He will be
tonsils out.
perfect. You will see.
Yeah, right.
He will be
That's a very-
perfect.
That's a very
Brilliant.
nice end.
Sorry, Joachim.
I would like to thank you all so much for joining us tonight. It is a pleasure to see you all from all over the world, from to the States, London or Turkey at the moment, Norway, Germany. It's really a pleasure to see you. Thanks for the amazing talks, and also thank you to the European Rhinologic Society for the support, and also thank you to Olympus. Thank you.
Thank you, Marlene.
Bye-bye.
Bye-bye.
Pleasure.
Bye-bye. Bye-bye.
Bye-bye.